Dr. Khatri was previously a fellow at Lenox Hill. Now he's joining me in my other practice out in Bushwick at Wyckoff Hospital as an attending neurosurgeon. He's also very interested in brain tumors, and he's going to be discussing with you guys today a case that we did a couple of months ago now. That's very interesting. It's going to have very unique anatomy. He's going to go over the imaging, the prognosis, and a really great result. And I think we've got some video involved as well. So appreciate you being around, Deepak. The floor is yours. Have fun, everyone.
Thank you. Thanks, Dr. D'Amico. Hello, everyone. Are you guys able to hear me?
They can all hear you.
All right. So on behalf of the Department of Neurosurgery at Lenox Hill Hospital, I welcome all of you to another seminar series. And today we are going to discuss the ventricular system of the brain. I'm gonna share. Just give me a second. Just give me a moment, please. I'm trying to get up my presentation. Josh, can you help me with the screen share?
Yeah. On Zoom at the bottom, do you see the green button that says share screen?
Yes.
Yeah, so if you click that, it'll let you select the screen that you want to share.
Okay. All right. Are you able to see my screen now?
Yes, it's working great.
All right, thanks. So we'll discuss the ventricular system of the brain. As all of you know, we have 4 ventricles in the brain. The 2 lateral ventricles, which can be seen marked with the pink color, and they are primarily contained within the cerebral hemispheres and connected to the 3rd ventricle, which is seen here in the light blue color. It's a midline structure. It's single, and it's connected to the lateral ventricles by the foramen of Monroe, and which is in turn is connected to the 4th ventricle, which is primarily infratentorial structure. And it is connected to the 3rd ventricle via the small duct we call the aqueduct of Sylvius, and it continues down further as the central canal. Okay. While trying to understand the anatomy, we need to conceptualize the brain as a 3-dimensional structure. So here are 2 different views. You can see the one on your left with my arrow mark there. You're able to see the brain from behind in an anterior-posterior view. You can see that there are these 2 lateral ventricles, and the 3rd ventricle is a midline structure. You can see the cerebral aqueduct there, and the 4th ventricle is sort of a rhomboid, which is situated behind the brainstem. So it is really important to understand the anatomy related to the ventricle, because it not only contains the CSF, but it is located in close proximity to very important neurovascular structures. So any pathology which is concerning regarding these ventricles, just to access that pathology, just to correct and operate on that pathology, we need to be aware of that anatomy so that we don't harm the patient. And on the figure on the right side, you can see the left lateral view of the ventricles, which we also saw in the previous screen. So as we know, the ventricles, they produce and they contain the CSF. The CSF, 80% of it is produced by the choroid plexus in the lateral ventricles itself, and rest 20% is produced in the 4th ventricle and some other structures in the brain. And basically, we have to know the flow of the CSF. It is produced about 0.3 cc every minute, and it's continuously circulated, as you can see in the small blue arrows here, which starts in the lateral ventricle and goes through the small connection here into the third ventricle, through the aqueduct of Sylvius into the fourth ventricle. And then you have different connections, which you can appreciate in this view. There are three different foramina which sort of give an outlet to the fourth ventricle, the foramina of Luschka on the lateral aspects, and the foramen of Magendie on the dorsal aspect of the fourth ventricle. So that's a basic overview of the ventricular anatomy and the CSF flow. This is a microscopic picture on your left side, if you're able to see. So the choroid plexus is basically, it's full of vascularity, and it has like these tight junctions, and it's basically a frond-like structure which with multiple microvilli, which basically increases the surface area of these capillaries, and it helps in production of the CSF. And this is the ventricular surface, which is lined by the ependyma, and on other side you can see the brain parenchyma in the green. And the picture on your right side basically shows how it is absorbed in the body through the arachnoid villi, which are closer to the dural sinuses. So that's another layer, the first layer, which is basically covering the brain. Now I want all of you to understand basically the correlation between how to read the radiological images and the anatomy. So I have put these two pictures basically to correlate. This is a coronal section. When we divide the brain into two equal halves, either in anterior and posterior halves. So this is a coronal section where you can see the important structures. You can see the corpus callosum here, and the two lateral ventricles, if you see on either side, which is divided by the septum pellucidum. And here you can notice the telechoroidae with the internal cerebral veins at the roof of the third ventricle, which is a small slit-like structure. And these two small blue structures on either side is the temporal horn, the tip of the temporal horns on each side. And you can appreciate the rest of the ventricular system here. Now, to correlate with this, this is a T2weighted MRI. So to basically look for the CSF, we do what's called a T2weighted image in the MRI, where basically the CSF, which is more like water in the body, and it gets demonstrated as a white structure in the T2weighted images. So you can appreciate that the two lateral ventricles here, these small dots, they represent the internal cerebral vein, and that's the black structure which is covering the lateral ventricles is the corpus callosum. And here the slit-like structure is the third ventricle. So this basically helps us to understand the pathology, to basically understand the changes from the normal. Now this is a sagittal view. The brain is cut into half from the right side, and the left side is basically cut in the midline, and you can appreciate that this is the corpus callosum, which sort of runs over the lateral ventricle, which is a small cavity. This small projection in the lateral ventricle is the thalamus, the caudate, and here is the thalamus. This is the third ventricle here. And the third ventricle connects here. This is the brainstem, which I talked about previously. And here is the fourth ventricle, which is in connection with the cerebellum here. And to correlate with that, you can see the T2weighted MRI image on your right side. I have put this picture basically to understand like a perfect balance between production and absorption of CSF is needed to maintain normal pressure inside the brain. Basically, any pathology which causes either an increase in the production, such as you know, the CSF is majorly produced by the choroid plexus. So tumors of the choroid plexus, they can cause increased production of the CSF. So if the CSF is produced more and it is not being absorbed so much, then it's going to cause increase in the volume inside the brain. And you know, the brain cannot expand similar to other cavities in the body, such as the abdominal cavity. So there is going to be increased pressure, which will lead to symptoms, as opposed to the other type of pathologies, such as which cause the decrease in CSF reabsorption, which can happen more frequently as opposed to the overproduction. And there are different pathologies which can cause this, and that also more frequently leads to hydrocephalus. So basically, we divide the hydrocephalus depending upon whether there is a block or whether it is still communicating type. So it can be communicating type of a hydrocephalus, or it can be a non-communicating type of hydrocephalus. Non-communicating means an obstruction anywhere above the level of the arachnoid granulations. Anywhere proximal to the level of CSF absorption is non-communicating type of hydrocephalus. So in this T2-weighted axial image, you can basically see that both the lateral ventricles, they are enlarged, and you can see this haziness, which is sort of a transependymal egress, which is usually seen, and it denotes, it is one of the indirect signs of increased pressure inside the ventricles. You can appreciate this, the transependymal egress more. This is a flare image, which is able to show it in a much better way. And these are the two lateral ventricles. These fronts are the choroid plexus and the septum pellucidum in between. This is a sagittal, mid-sagittal section of the brain, and it shows that you can see the lateral ventricle, it is enlarged, and as compared to the normal image on your left, this is a normal image, you can definitely see that this is the lateral ventricle on the left side. It is definitely enlarged, and the third ventricle is also enlarged, and this small dot-like structure is the massa intermedia, which sort of connects both the thalami on the opposite sides, and you can see the cerebral aqueduct here. Now, important things, these are the different radiological, how do we get to know that, or how does a radiologist tells you that there is hydrocephalus in the brain? Basically, these are the radiological signs that you are able to see the enlargement of the ventricle, enlargement of the third ventricle, enlargement of the foramen of Monro here, and you can see the fourth ventricle is also enlarged. So I want you to remember this. The fourth ventricle is also enlarged in this one, which is an important sign to say that it is a communicating type of hydrocephalus. Another important observation here, if you are able to look closely at the roof of the third ventricle, you will be able to appreciate that the corpus callosum, as compared to the opposite side, it is much more thicker on the left side. So because of the pressure, it gets thinned out, and it sort of turns into a bow. So there's a bowing of the corpus callosum as well. Now, as opposed to the previous image, I have put this image, you can definitely see a small round lesion at the level of the foramen of Monro, which is causing blockage of the lateral ventricles, preventing the drainage into the third ventricle. So we are able to appreciate that the lateral ventricles are enlarged, and there is transependymal egress, which means that the pressure in the lateral ventricle, it is rising. But because there is a block at the foramen of Monro, the third ventricle still remains to be normal. This is the third ventricle here. It still remains a slit-like structure because there is no CSF flow. So there can be different type of obstructive lesions in the brain. This is the same image, which you can see here. It is marked by the arrow here, the transependymal egress, a lesion at the foramen of Monroe. And if you appreciate that in the sagittal sections, you can see this lesion here, and you're not able to see the third ventricle or even the fourth ventricle. So when you say hydrocephalus, you need to be sure what basically you're talking about, because hydrocephalus is a result. You need to know about the pathology which is causing that. So as opposed to the previous image which I had shown to you, to compare with that, the third ventricle here, this is another cause of an obstructive hydrocephalus. If you are able to appreciate, this is this small slit-like structure which goes from the third ventricle to the fourth ventricle here. It is called the cerebral aqueduct, and there is stenosis in that. So this is a patient with aqueductal stenosis, which in turn leads to the obstructive type of hydrocephalus. So important to note that the fourth ventricle remains normal in size. I put this picture basically actually it's the Vitruvian Man who was painted by Leonardo da Vinci, who appreciated the symmetry in human body anatomy and functions. So when we talk about symmetry, the reason I put that picture was there are these different pathologies. So let's just suppose there is a pathology which blocks the cerebral aqueduct, as can be seen here. So it will still not be able to block the foramen of Monroe. So anything which is proximal to this will be dilated equally and on each side, of the right and the left. So both the lateral ventricles and the third ventricle will be dilated. So this is symmetrical hydrocephalus. As opposed to the pictures below, you are able to appreciate that the right side lateral ventricle is more dilated as compared to the left side. So there has to be some block at the level of foramen of Monroe on the right side. So just by looking at the picture, you are able to guess the location of the pathology. So it is really important to look at your radiological images very carefully, not only to define the pathology, not only to identify the level of the obstruction, but even for to formulate your surgical plan, you should be able to read your images. That's why I have put all these pictures, so that you're familiar with the basic radiological images associated with these pathologies. So whatever is the cause of the obstruction, either at the level of arachnoid granulations or anywhere proximal to it, it leads to increase in pressure inside the brain. And basically, because of this increased pressure inside the brain, there are multiple symptoms which can happen. As you can see on the upper left picture, this child with the hydrocephalus, he has an increased head size, he's irritable, and you can appreciate these scalp veins which are sort of distended. And the reason for that is because of the increased pressure, it puts a pressure on the dural venous sinuses. So these are not able, the scalp veins are not able to drain into the venous sinuses. And the picture on your right side, you can see the raised intracranial pressure can cause a very severe headache in adult patients. And here you can see it can also cause cranial nerve paresis. As you can see, it's a left side sixth nerve paresis in this patient. And also what we appreciate is a sun-setting sign. So this is a dangerous sign. This alerts the surgeon basically that the pressure is too much. It basically happens because, let me show you the anatomy, back to anatomy again. If there is pressure, these are the colliculi, which sort of controls the, it controls the extraocular movements at the back of the midbrain here. So if you, if there is some pressure over the colliculi, then you can get what is known as a sun setting sign. So it depicts a grave sign. And this small picture in your red, that's the fundoscopic examination of the eye. So hydrocephalus, if chronic, increased pressure can lead to blindness. It can cause blurring of vision and blindness. And this is basically the optic nerve head. When you shine light, when you look with the ophthalmoscope in the eye of a person, this is how you're going to see in a chronic hydrocephalus with increased pressure. So ever wondered why there is increase in head size in the children and just headache in the adults? That basically happens because the sutures in the skull, they are not fused in the children. So because they are not fused, skull is still able to expand in a response to the increased pressure. So that sort of compensates early features, and because it is able to, it is more receptive to the increased pressure. But once the head size is enlarged, there's no more space there, and the pressure keeps on increasing, which is not the case in adults, because after the fusion of the sutures, there's no more space in the brain to expand. So this is basically a few of the symptoms of hydrocephalus which can happen. So coming back to this picture, this is a CT axial scan. I put this picture basically to show you, I've shown you different pathologies related to the obstruction. We have discussed all the obstructive pathologies here. Remember the first image I told you about, there are certain tumors of the choroid plexus, which sort of produces more CSF, and then they can cause hydrocephalus. So this white structure in the left ventricle, left lateral ventricle, is the choroid plexus tumor. It's a choroid plexus papilloma. And the shape here, it's more characteristic of a choroid plexus tumor. It's more frond shape, and it's associated with hydrocephalus. Basically, this is the detailed anatomy here. And I want you to understand these are the different views. This is the sagittal view. This is a top-down view. And this is an anterior-posterior view. And the blue structure here is the fornix, which is connected to the hippocampus and the mammillary bodies. I want you to remember this, because I'm going to show you a next video about the colloid cyst. So all this discussion basically was to orient you before I take you to the video, so that when I use those terms, you are able to understand the anatomy in a better way and understand the video. Okay, so let's go to the video. So we operated this patient. He was a 46-year-old male who was referred to us from another hospital with complaints of intermittent headache. Remember, we discussed about the symptomatology, and headache is one of the prominent symptoms of raised intracranial pressure. It can also lead to ataxia, which is difficulty in walking. So difficulty in walking can occur because the corticospinal tract, they are located in close proximity to the ventricles on each side. So increasing the ventricular size can sort of put pressure on them and can cause ataxia. Or it can cause pressure on the brainstem and can cause ataxia. So there are multiple reasons for that. So this patient presented to us with intermittent headache and ataxia for 1 month. And he had been having vomiting for 1 day. So vomiting shows that the pressure was really high. So vomiting is another grave sign of raised intracranial pressure. But luckily, this patient did not have any visual symptoms. On examination, he was alert. He was oriented ×2. There was mild right side facial weakness, but there were no motor deficits. All right. Now, let's discuss the radiological images of this patient. So this is the coronal section, MRI. You are able to appreciate that there is a small round lesion on the left side. And same image you can see in the sagittal section that it is occupying the region of the foramen of Monroe. And you are not able to appreciate the third ventricle. Another important thing I want you to notice is the fourth ventricle. Remember, we discussed about this. So it shows that the fourth ventricle is not enlarged. So the level of, we know about the pathology that there is a tumor at the foramen of Monroe. We know about the location. So it is an obstructive type of hydrocephalus. So one important thing, remember we discussed about symmetry. So a lesion, now here is a lesion which is primarily blocking the left side. Then why both the ventricles, they are more or less symmetrical. So we'll find out the reason for that. This is interesting here, okay? I'm gonna fast forward through the video. So basically, after knowing the pathology and the location, our plan was to go from the right side because that's the non-dominant side and it is more safer to approach. There can be several approaches. I'll show you in a picture here. This is the ventricular system. So basically, depending upon the pathology, we can have different surgical plans, and we have to tailor our craniotomy accordingly. There can be, like, if it is located more anteriorly in the ventricular system, we can go from an anterior frontal approach, or from anterior transcortical approach, or a transcallosal approach, or a posterior transcallosal approach, or a posterior transcortical approach. So each of these approaches, they're basically dictated by the lesion itself. Like the level of the lesion, it tells you that this approach is going to be more safer. It's going to provide an easy access to the pathology in a more safe manner.
Great job, Deepak. Keep it up, bro.
Sure. Thanks, Dr. Langer. So based upon the level of the obstruction, we define our approaches accordingly. So here, back to the video again, we have this obstruction at the level of foramen of Monroe on the left side, yet we are going from the right side, because it's important to realize that we have to basically, when formulating a plan, we have to basically weigh the risk and the benefits of the approach. So if we approach from the left side, it would have provided us an easy access. But remember, the left side is the dominant side. So you don't want to give somebody deficits after your surgery just because of your surgical access. So we decided to go from the right side. And since we are going through the cortex here, using this tube, which is called as a Y-core tube. So it's, you can see that here is an occluder. There are basically two parts of this tube. This is a 717, which means it's a particular size of the tube which we use. And since we are going through the cortex, it's a transcortical approach, okay? If we had gone in the midline, that would have been a transcallosal. Remember, I showed you the corpus callosum in the midline. So we have to basically weigh the benefits and the risk of each approach before we deal with a particular lesion. Let me show you. Okay, so after we put in this tube, we were in the right lateral ventricle. So the way we identify the ventricle, let me take you back to this. So this is a more complicated sort of picture, but let me explain it and make it easy for you. Focus on the left side, left upper side of the screen. And if I cut the brain into, from like a slice from above. This is a top-down view. So you can see both the lateral ventricles here, and these are the foramen of Monro on both sides. And this is the thalamostriate vein, the small streaky veins, which you can appreciate here, is the thalamostriate vein. This is the choroid plexus, which runs in the floor of each lateral ventricle. So they sort of guide you to the foramen of Monro. And this is the zoomed in image of the same. You can appreciate that this is the thalamostriate vein, and this is the choroid plexus here. So if, let's just say, let me go back to the video. I want you to understand what I'm trying to say here. So if I'm coming from the right side, there are equal chances that you're going to land up in the right lateral ventricle, or you can actually land up in the left lateral ventricle, because you do not know when you're passing your tube right there. So it is important to identify your location before getting further with your surgery. So the way you can identify whether you are in the right side or in the left side, this can be confirmed with the anatomy itself. So if you are accessing from the right side and this thalamostriate vein, you are able to see it on your right side, then you are in the right lateral ventricle. But if you are able to see, if you are accessing from the right side and the thalamostriate vein is on your left side, that means that you are in the left lateral ventricle, because the thalamostriate vein is a lateral structure. So it is really important to understand the anatomy when you enter the ventricle. So this is how we entered the ventricle. This is the top-down view through the tube. We used an exoscope. Let me pause here. I want you to appreciate these structures here. This is the thalamostriate vein, which is marked by the blue arrow. And since it is on our right side, we can confirm that we are in the right lateral ventricle. And this is the anterior septal vein, which runs along the septum pellucidum. And this is the tip of the choroid plexus. Remember, I told you it is sort of frond-like structure, which is really friable, really vascular. So you have to be really careful when dealing with tumors of this location or dealing with any pathology, because if you injure any of these structures, you might run in trouble. There can be a lot of bleeding, and it's full of CSF. So it becomes really difficult to control the bleeding if you don't take care of these structures. And this is the column of the fornix here. So the fornix is another important structure. It's really important. Let me discuss the anatomy of the fornix with you guys. So this is a pictorial diagram here. This is a sagittal view. The fornix, if you can see the dark blue structures here, you know the lateral ventricle, the third ventricle, and this yellow structure here, if you can see by my arrow, is the hippocampus and the amygdala. So the hippocampus and the amygdala is connected with this dot here, the small round structure, which is called as the mammillary body. And it is connected by this, the yellow structure here. So this structure is present on each side. This is a top-down view of the brain. You can appreciate that this is the hippocampus on each side connected to, it goes anteriorly above the third ventricle. It forms the roof of the third ventricle. And it is also forming a boundary of the foramen of Monro. So this structure is really important because it forms a part of the Papez circuit. We call it the Papez circuit, and it connects all these structures which I mentioned to you. This circuit is really important because it helps in the control, the cortical control of memory function and emotional control. So if you damage this during your surgery, the person may have deficits in the memory. So you don't want to do that. Let's go back to the video. All right, so remember, this is the column of the fornix, which forms the anterior boundary of the foramen of Monro. So we have to be really careful there. This is a bipolar cautery, which we use, and the suction on the left. So we as neurosurgeons, we always work with both the hands. You never operate with one hand. So this structure, remember I showed you the anterior septal vein. Right now we are working on the septum pellucidum. Remember, we approached from the right side and the lesion was on the left side. Okay, so there is septum pellucidum between you and the lesion. So we have to make what we call as surgical windows. Okay, so, and we, at the same time, we have to preserve the septal vein. So we make multiple windows to access the lesion. So here in this case, we made windows. The small window you can appreciate anterior to the septal vein here, it is the anterior surgical window, and another surgical window posterior to the septal vein just to preserve it. And after we made the windows, you can see that this slightly sort of gooey structure, which is pale yellow in color, is the cyst. This is the cyst on the opposite side, occupying the left side foramen of Monro. So it is really important because it's a very highly zoomed in image. So the way we can take out lesion is to remove them in totality, which obviously is going to need a larger size of your surgical access. But here we are limited by the vascular structures. The anterior septal vein, it limits your access. So just to preserve this, we made multiple windows which are smaller in size. So the way we can operate on a larger cyst on your left side is to puncture into the cyst, take out its contents, and reduce its size. So this step is, we call it as internal decompression, okay? So we opened the cyst and removed the solid components. This is the cyst wall. This is the cyst wall here. And we are removing the solid components of the cyst just to reduce its size so that we can remove it through these smaller windows. Now, I want you to focus here. When we adjusted our tube sort of more posteriorly, remember we've made only two windows. The one was anterior to the septal vein, another was posterior to the septal vein, but there is another window here. So when I started this discussion, I showed you that why should left-sided pathology lead to a symmetrical enlargement in the ventricle? So that's not going to happen. That should not happen until unless there is another communication between both the ventricles, which sort of decompresses left-sided enlarged ventricle into the smaller right ventricle. So this was this is a septotomy, which probably was a compensatory response, which could have happened because of the increased pressure on the left side. So that is why a left-sided obstruction in this patient would have caused symmetrical enlargement of both the ventricles. So we can appreciate the colloid cyst on the left side here. These are the tumor forceps which we use. Basically, another important technique when we are operating in tumors, one is internal. We discuss about internal decompression. That is one important surgical strategy. Another important strategy is traction and counter traction. So there's a dictum that never pull anything in the brain. So we do not do that. So unless we provide counter traction to it. So a traction and counter traction technique is really important. It is a fundamental basic in while operating for tumor surgeries. So that sort of safeguards you towards injuring anything. So it's a really important technique which we follow. So using traction, even with your suction, we can use the traction. So we use the cautery to, let me show you again. So using the bipolar cautery here, let's go back. So this is the bipolar cautery, and another important technique, just like if you boil an egg, it solidifies. So this bipolar cautery, when you apply to the tumor, it sorts of increases the temperature and it coagulates the surface. So it shrinks down the size of the tumor and it helps in hemostasis. So these are the important functions of the cautery. So it shrinks down the size of the tumor and it causes hemostasis. So we use all these techniques basically to safeguard our approaches. Now here, you can appreciate that this is a huge cyst. It's in the lateral ventricle on the left side, and anteriorly it is going into the foramen of Monro. This is the foramen of Monro on the left side. So here we are using traction and counter traction technique. We moved the cyst back, posteriorly back from the foramen of Monro into the lateral ventricle. So the goal of the surgery is to basically establish a normal CSF pathway. So we operated on this tumor basically to establish a CSF pathway. This instrument, let me show you again. This is an endoscopic bipolar cautery. So as opposed to the normal cautery which we use, the blue colored one, this provides a long handle and it has small calipers at the end. So it's basically structured like this, and it provides you a single handle, which is longer, which is more safe. And it was a really useful instrument in this surgery. So remember, traction and counter traction. Using the suction, we are lifting the wall of the cyst here and sort of removing the solid contents of the cyst here. And this is the cyst wall, which we have to remove. If we do not remove the cyst wall, it can lead to, because the cyst wall is the actual site of production of the contents of the cyst. So it can, if we leave the wall behind, it can cause secretion of the cyst content back into the cyst and reform. It can cause a recurrence of the cyst. So it is really important to remove the cyst wall. And we irrigated with saline at the end to confirm hemostasis. Now back to anatomy again. This is the anterior septal wall. The structures marked by the asterisk here is the left and the right side foramen of Monro. And this is the body of the fornix. Remember, I told you about the fornix. So the body of the fornix forms the roof of the third ventricle, and the columns of the fornix, which sort of curves anteriorly and forms the anterior boundary of the foramen of Monro. So we have to be really careful to preserve these structures. This was our post-operative image. As you can see, we achieved a gross total resection of the cyst, and obviously the ventricle size is still enlarged. It takes a little bit of time, maybe a couple of months, for the ventricles to go down. You're not going to see it immediately, but definitely you can see that the lesion is no more there. So the post-operative course, the patient had complete resolution of his symptoms. His exam was stable. We had put in an EVD. EVD is basically an external ventricular drain. Whenever you operate in the ventricles, so since we use the tube, we already had an access to the ventricle, the right lateral ventricle. So just because we removed a tumor, and as opposed to operating anywhere else in the surgery, when you're operating in the brain, you cannot put sutures to close your bleeding. So we have to be very careful, especially in the ventricle. Let's just say the patient bleeds on post-operative day 0 or post-operative day 1, and you have no way of knowing that the patient is bleeding until unless you do a scan or the patient deteriorates. So we put in an EVD. It's a simple tube which we leave inside the brain, and it sort of drains the CSF at a particular pressure which we can set. And if there is any bleeding, you will be able to see the bleed in the brain, and accordingly, it's going to drain accordingly, and it can help somebody's life. So EVD is a really important thing to do when you are operating in the ventricle. And we were able to discharge this patient on postoperative day 3. He's doing well. I think that concludes our video. So I would say the takeaway points from this presentation is to know your anatomy well when you are attempting to remove any lesion in the ventricle. As a student at your level, I would say it is important to identify the radiology. It is important to understand the radiology so that understand the normal structures, understand different orientations of the radiology so that you are able to appreciate the pathology. You are able to differentiate from what is normal from a pathology. So that is it. I'm open for questions. Please let me know.
I'm going to open the chat up right now for questions if you want to stop screen sharing and check out the chat.
Sure.
They come in pretty quickly though, so just answer the ones you can get to.
Yes.
Also, a good one that like we always like to have the speakers talk about is just like your pathway into medicine, how you got to where you are today, what inspired you, if you want to go through that a little bit.
Oh, sure. So I did my medical school from India, and I basically decided I wanted to be a doctor from my childhood. And I got into med school. After that, I knew after a few years, I knew that I want to be a surgeon. But I did not know as to what kind of surgeon I want to be. The reason for that was during my first year of med school, I loved anatomy. I loved anatomy more than the physiology. So that's like when I talk to my friends who are surgeons in other fields, this is one common thing which I have found, that most of the people who end up being a surgeon are usually the ones who like anatomy more than other subjects which are more theoretical. So I really loved our cadaveric dissections and anatomy lectures much more than anything else. So that was my reason to be a surgeon at first. And out of that, I think brain was one thing which fascinated me more than anything. And that was the reason for me to take up neurosurgery residency. And when I was a resident, I sort of connected more to patients with brain tumors because like my project was basically, I was working on patients with glioblastoma, how it affects their lives and the quality of life. I know that everybody knows that it's a fatal tumor and patient survives closer to 1 year, but not many people know that, or I would say rather, we do not frequently do not take into account the quality of life of the patient and the patient family itself. So it takes a lot of toll on the family. So my project was basically to assess the quality of life in the patient and the patient family after a diagnosis of brain tumor is established. So that's how I got interested in brain tumors, and I did a fellowship there. And then before moving to Lenox Hill, and last year, I just completed a fellowship at Lenox Hill in brain tumors with Dr. Bokwar and Dr. Langer. So that was my story of choosing this path.
If you want to just now take a look at some of the other questions.
Sure. How would a neurosurgeon handle a bleed if any occurs? So that basically, I sort of discussed that in the video itself. the way it works is I had this unique opportunity because I train in general surgery as well. So when we operated on, let's just say abdomen, you are able to see, you're able to, it's on a much larger scale. You can put in a suture, you can tie the bleeding vessel, as opposed to the brain where you're not supposed to leave any foreign body inside the brain. So the way we can control the bleeding depends upon the site of the bleeding and the rate of the bleeding. So if it's a small venous bleed, it can it can be controlled by pressure, or you can use, we have different things available, such as the Surgicel or the gel form, or there's a Surgiflow. These are all different things which can help us to control the bleeding. And obviously we can use the Khatri. But we try not to cauterize, especially in regions of the brain where, let's just say, it is going to harm the patient. So if it's in an eloquent location, if it is controlling an important function of the body, then we do not cauterize. We try to preserve the normal supply as much as possible. How do you stay sane when you're learning the anatomy of the brain? Okay, that's a really interesting one. I think personally, like, as far as I'm concerned, I was moved by anatomy. So I would say it gave me more enthusiasm and more energy when I was a medical student. And funny thing is, we used to have the cadaveric dissections just before our lunch. So we used to do dissections and then go to the lunch. So I have had that. So I survived that. What is the approximate salary range coming in as an attending neurosurgeon? Well, I think that depends upon what level you're joining in and what institute you're joining in. So I know money is important in life, but thankfully doctors earn well to sustain their lives. Okay, they're coming in too fast. How is your work-life balance? It's basically, as I showed you, you need to you need to maintain that balance in life. So it's all about balance. It's all about symmetry. So I'm a fan of symmetry. So you have to sort of try to develop kind of choices which it becomes a part of your life. I mean, just to be a neurosurgeon, you start thinking of things, you start seeing things in a different way. So it's probably during the training itself, you get used to it. So it becomes a part of your life. Could we have your email for further questions on colloid cyst or your path in medicine? Sure. Joshua, can you help me with that? You can have my email. My email is dkhatri@northwell.edu.
Sounds good. Yeah, if anyone emails me and asks me, I'll send them your email over.
Sure, thanks. What are some tips you have for post BACC students? I don't know what that means. What's, Joshua, can you help me there? What's post BACC? Oh, post-baccalaureate students, if I'm not wrong, who want to pursue surgery. So the way it works is I train in a different setting, and then I moved to this country. I believe if you are here, then after your college, you have to take your MCATs, get into the med school. After graduation, in the final year, usually students end up applying for residencies, and that's how you get into surgery. And surgery residency is usually 5 years here, and neurosurgery residency is a 7 years training here. And if you want to subspecialize, then you have to apply for fellowships, which can be interest areas of your choice. They can be tumors or vascular or skull base or endovascular. We have different kind of trainings. What is the quality of life for a child with severe hydrocephalus? Do they live long? So basically, remember I told you hydrocephalus is a result. As you said, a severe hydrocephalus. So child, it basically depends on what age they got it and what is the baseline functional status when they were diagnosed. So there can be certain congenital causes as well. So as the child is growing, their brain function is not yet mature. So it basically depends upon all these things, that how they gonna do, because most of these diseases, they can be secondary or they can be part of a much larger symptomatology. So hydrocephalus is just a part of it, which most of the time does not determine the outcome, just because there are many other associated conditions with it. Any advice for med students who aren't getting cadaveric lab experience due to remote learning? I would say it's a difficult situation right now, but when I was training back in 2002, we never had the luxury of internet. So, but now you're able to like Google so many things. I picked up all these pictures, all these radiologies from Google yesterday. And you can even see 3D anatomy on the internet. So if you are not able to join a cadaveric lab, then I would still suggest that it should not limit you from learning anatomy. I know for a fact that obviously cadaveric lab has its own advantages, but still it should not restrict you from learning anatomy. You can do that on the internet.
All right, I think we're going to stop you here, but thank you so
Sure.
much.
Of course. Sure. Thank you. Thank you, everyone.